Hi there, my name is Matt Holland, and I'm going to be talking to you today about intracranial tumors and physical therapy with the spring 2020 class of PTA P 213. So let's go ahead and get started. First, I want to talk to you about the pathophysiology and etiology of intracranial tumors. So a brain tumor, it's basically a mass of cells that are growing exponentially at an uncontrolled rate. The body's not using its cutoff mechanisms to stop this or to cessate those growing cells. So tumors can be cancerous or non-cancerous, but even more, there's a sub or more primal subcategory, and that's primary and metastatic. Primary is the one that you're going to find your benign or malignant categories within, and metastatic is basically everything else. So primary tumors, they're going to be the ones that are formed in your brain or with the tissues that are just around the brain. That's why they're also known as glial and non-glial cells. And that's, like I said, where you're going to find your breakdown of malignant or benign. Now, metastatic tumors, those arise pretty much anywhere else in the body. They can be a result of breast cancer, lung cancer, prostate cancer, lymphoma, just any sort of other cancer that's in the body, and then those cells break off and travel in the bloodstream usually to the brain, and that's why they're still a form of brain cancer. But those are called metastatic, and all forms of metastatic tumors are considered cancerous as well as malignant. So I found this pretty interesting quote. It says that metastatic tumors to the brain affect nearly 1 in 4 patients with cancer, or an estimated 150,000 people per year. So that's saying that 1 in 4 cancer patients or brain cancer patients develop their brain cancer from a metastatic source. There are different forms of tumors. Brain tumors can cause several health, neurological, and physiological issues. So the way that they work, they'll continue to expand and compress on the cerebral tissues, and it results in a cerebral edema. And what these do, that's where our role comes in, but we'll get to that in a little bit. So the forms of tumors. This first slide I have for you, by the way, each of these are links, and you can follow them. If y'all get a copy of this, I'll link you a copy of this PowerPoint. But each of these is a followable link. They'll take you to a page that talks about each of these types of tumors individually. And then, let's see. So these are the tumors that are more likely to be in adult patients. Now, they're not saying that these specific tumors are not able to exist in pediatric patients, but these are the ones that are more common with adults. Now, for the children, we have this list right here, and that's on the side. This again, more followable links. You can click on these, and they'll take you directly to an information source about those specific tumor types. And on this side of the screen, we have a chart that I found. It's actually a scale by the World Health Organization. And what they do is they break down each of the types of tumors into a gradient. And you have grade 1 all the way to grade 4. And these grade 1s are like, they're slow growing. They're not spreading as quickly. They're easy to remove. While these grade 4 are more intense and are more difficult, and they're harder to remove. So you want to try to avoid grade 4 tumors as much as possible. So get them diagnosed early. Moving on, clinical signs and symptoms to help you get those diagnosed early. Basically, the tumors you're going to experience symptoms based on where the tumor is. And that can fluctuate wildly based on which lobe it's directly affecting. But some normal or very common symptoms are headaches, nausea, vomiting, seizures, unusual sleepiness or lethargy, behavioral personality change, and unexplained weight loss and weight gain. On this next page, I have a nice little visual here for you. I like it. It helps me a lot in remembering the common symptoms with them. I pulled this from Very Well. They're a pretty trusted organization. So headaches, they tend to be dull, persistent, throbbing headaches that occur less often. The seizures, I don't know if you know this, but seizures are typically the very first sign that people will take seriously enough to go get checked out at the doctor. So seizures, of course, vomiting, and it's the type of vomiting where you stand up too quickly, or you get up, roll over in bed, you all of a sudden feel a need to throw up. That's the type of vomiting that we're talking about with tumors. Cognitive changes, such as memory, problem solving, concentration, confusion, or spatial problems. Vision problems, such as like seeing a flashing light in a room where there's not any light produced at all. Double vision or diplopia, blurring or loss of vision entirely. And for speech changes, they may have difficulty forming or finding words. They say things that make little or no sense, and they're hard to understand. And it's hard for them to understand what others are saying. So methods for diagnosis, we're going to talk about the frontal, parietal, temporal, occipital, cerebellum, and brain stem, and what each of those locations mean for your symptoms. If it's a frontal, it's going to have an intellectual decline, personality changes, or a loss of smell even. Parietal is going to have a sensory change, coordination impairment, or a lack of recognition. Temporal, you're going to have auditory hallucinations, inability to understand speech, vision changes, depersonalization, or deja vu. I believe Miss Kim mentioned deja vu to us when we were learning about temporal lobe. Occipital lobe, visual hallucinations, obviously, cortical blindness, and visual field deficits. In the cerebellum, you're going to see things like incoordination or difficulty with fine motor activity. And in the brainstem, you're going to find numbness, weakness, double vision, uneven pupil dilation, dizziness, droopy eyelids, or even a loss of consciousness. Let's see, for another way altogether to look at diagnoses. There's a group at AIM that's been looking at lactate in the bloodstream, and they're finding that elevated levels of lactate actually indicate that a person has some sort of tumor growing inside of them. They don't know why that's linked because they can't find a reason yet. But they do know that if you're above the regular 2 millimoles per liter of blood of lactate, then you're at risk or you have some sort of tumor in your body. Other than measuring values and the symptoms, you can also find ways to diagnose with MRI, radiography, X-ray, CT, ultrasound, PET scan, and nuclear medicine scans. The point of all this I want to make is that there's tons of tests to diagnose a tumor, but no single test is used to test for a tumor, or rather a plethora of tests. So hit them with a bunch of different tests, and you're more likely to get accurate results. Future methods for diagnosis. There's a CNS group or CNS oncology group known as Future Science Group, and they've been pursuing a way to identify tumors based on regions of the brain, not just the lobes, but like the regions. So I got one of their graphics from their study. I think it's kind of useful. Like I said, this is going to be in this PowerPoint for you if you want it to save this document. But basically, I'm not going to read them all, but it breaks down what types of symptoms you're going to see with different areas. Like if it's a central tumor, you're going to see all of these different ones, and that's going to be a percent based on how many out of all the symptoms you're going to get, this is the most common symptom for this region of the brain. I hope that makes sense. So moving on, medical management. So the big three, as they're called, that I've learned are hypertension, hydrocephalus, and disruptions of vital functions. Each of these things are critical in nature, and they can lead to long-term lasting effects to even death. And therefore, the surgical treatment is typically the preferred treatment for removal of a tumor. That means excisions or craniotomies, just to remove that massive cell. And then they're going to hit it with radiation and chemo and different medications. I'm sure you all know someone that has cancer and all the crud they're going through. But there are some new advancements. There's research into hyperbaric oxygen therapy. And if you remember from earlier, I mentioned that an individual with a brain tumor, especially once it's excised, is going to have that cerebral edema. And what they found with the hyperbaric oxygen therapy is that it reduces the reduces the edema in the cerebrum, or in the cerebral tissues. And this is likely due to a hypoxic effect. So there is advancement going on, and that's what they're looking at now. I just want to read you this quote real quick. Improving tissue hypoxia has significant curative effect on decompression sickness and thrombosis, can reduce tissue edema, that's what we're looking for, and brain edema can be controlled, and it can inhibit the growth of some aerobic and anaerobic bacteria, especially those anaerobic and aerobic bacteria are ones that you're going to find in a lot of open brain surgical removals. They're going to be bacteria that was unintentionally picked up in that situation usually, or some sort of cut they have compromised immune systems after surgery. Everyone does. And if you get some sort of cut or scrape and you get any bacteria on that, it's going to travel into the blood and likely into the brain. So, moving on. Physical therapy management. What I found is that a lot of the symptoms and signs for treating a patient with a intracranial tumor is that you kind of tailor the things or the treatments to them individually, because every tumor is going to present with a little bit different of a symptom, and so not every patient's going to be treated the same. One thing that is really common amongst all of the types of symptoms is a sort of a stroke-like thing where they're hemiplegic on one side and their other side's completely unaffected. And so they developed a technique called CIMT, or constraint-induced movement therapy. And I want to show you a video on that real quick. I don't have a whole lot of time left, so I'm going to have to hurry, but we're going to watch this video if we can. Ignore all my tabs, they're for studying. And we're not going to watch the whole thing, just the first little bit.
Nice. Way to get in there. It's that thumb that's holding you up. There you go. Good. Way to take
and I've actually used one of these mitts in therapy before.
Movement therapy.
In my last
Most
rotation.
of our patients that come here have one hand or limb that is affected and is not being used. So they've learned non-use of that hand. So now what we're trying to do is to teach the brain and reprogram the brain to use the affected hand more effectively. We actually have a mitt that is placed on the non-affected hand, and they sign a behavioral contract stating that they will commit to wearing this 90% of their waking hours, and that will be run for a 2-week period that they come for therapy for 3 hours a day. That's awesome.
Okay.
Good work.
Don't have a whole lot of time left, so I'm going to switch back. All right, so like I said, they wear this for 90% of the 2-week period while they're trained with their impaired limb, and their non-impaired limb is restrained. This just helps regain some of that function. So other than that, like I said, it's specifically tailored to the individual. I found this statement. It's not really a quote, but a statement about what exactly PT does with neuro-oncological patients. So this is actually from the Neuro-Oncological Physical Therapy Foundation, and they said that the PT's biggest goal is going to be to understand the procedures, the treatments that the patient is going through. So like they need to understand that chemo is going to drain this person of strength, and removing this tumor is going to help them get better, but it's also going to cause this side of their body to be weak, or they're not going to be able to speak as clearly, so they're going to need speech therapy. Just therapists in general have to tailor their treatment to the individual patient, because not every intracranial tumor patient is going to be the same. And I believe, yep, that's it. This is my works cited page. I hope you all learned something and enjoyed the topic. I know I did. Just cutting it out at 14 minutes and 30 seconds, so sorry for taking such a long time, but it was as quick as I could do it. Thank you all so much. Have a good day. Bye.